If a woman suffers 3 consecutive miscarriages, I mean, it is entirely natural for her to feel like her body has just permanently failed her.
Oh, absolutely.
Mm.
The psychological toll is just immense.
Right. And you would assume the biological odds of a successful pregnancy have basically dropped to zero at that point.
Hmm.
But here's the biological truth. Without a single medical intervention, without any treatment whatsoever, she still has an 85% chance of a healthy live birth in her next pregnancy.
It's incredible, yeah.
Welcome to a special, clinically focused deep dive into our source material today. For you listening, whether you're a medical student prepping for boards, a young healthcare professional, or just an insanely curious lifelong learner, we are unpacking the PreTest Obstetrics and Gynecology 14th edition.
And we are really getting into the weeds today, the why and the how behind the clinical logic.
Exactly, because we're not just reading textbook lists, we're analyzing the pathophysiology, the counterintuitive data, and the rules that drive modern OBGYN practice. So let's start with that 85% statistic because, frankly, that defies basic probability.
It really does. I mean, it's one of the most powerful paradigm shifts in early obstetrics.
If a system fails 3 times, you assume the system is fundamentally broken, right? Like a weighted die.
Right, but it forces us to stop looking at recurrent first trimester loss as this, systemic maternal failure. We have to start looking at it as a highly effective, albeit really painful, biological quality control mechanism.
Okay, so what is protecting the next pregnancy to allow such a high success rate then?
Well, the protection comes from the fact that the maternal system isn't broken at all. The vast majority of these early losses, they're driven by random genetic errors in the embryo itself.
So not a hostile uterine environment.
Exactly. It's not the environment. The textbook points specifically to chromosomal abnormalities. Trisomy 16 is actually the single most common cause.
Wait, so the embryo possesses 3 copies of chromosome 16 instead of 2.
Yeah, and that blueprint is simply incompatible with life. So the maternal body recognizes that genetic incompatibility early on and terminates the development.
Ah, I see.
Because the error is a random, meiotic, non-disjunction event, like a fluke during cell division, the odds basically reset with the next conception. The die isn't weighted at all.
That completely reframes the entire conversation around early pregnancy complications for you as a clinician.
It really does.
Now, when we want to actively screen for viable but generically abnormal pregnancies, like
Yeah.
Down syndrome, the source material emphasizes that a single test just isn't enough in the first trimester.
No, definitely not.
We look for neutral translucency, right? That fluid buildup at the back of the fetal neck on an ultrasound. But the text insists on combining that with serum markers like PPPA and free or total beta-HCG.
Yeah, because using neutral translucency alone, it yields an unacceptably high rate of false positives and false negatives.
Right.
By adding the biochemical markers, we get a much clearer picture of placental and fetal function. But, a combined abnormal screen is still just a statistical red flag.
It dictates the next clinical maneuver. You don't just jump to a diagnosis. You offer genetic counseling and a definitive karyotype via chorionic villus sampling or amniocentesis.
Which carries its own risks, of course.
Yeah.
And that highlights why we don't just perform CVS on every single pregnant patient. We use the non-invasive screens to justify the invasive diagnostic tests.
Makes sense. So beyond internal genetic errors, the first trimester is also uniquely vulnerable to external teratogens because the placental barrier is surprisingly permeable.
Very permeable, yeah.
The textbook singles out a few common antibiotics to absolutely avoid. Tetracyclines, for instance, they bind tightly to developing calcium.
Right, which is why exposing a fetus to tetracycline
Hmm.
results in permanent yellow-brown discoloration of the deciduous teeth and hypoplasia of the enamel.
Wow.
The drug literally integrates into the calcifying structures as they form.
And then the sulfonamides carry a different, more immediate risk to the fetal blood supply, don't they?
Yes. Sulfonamides trigger severe hemolytic anemia. The fetal red blood cells are destroyed way faster than the liver and spleen can manufacture them.
Resulting in profound fetal compromise.
Exactly.
So as we move out of that highly sensitive first trimester, the nature of the clinical threats undergoes this massive shift. We transition away from those microscopic genetic blueprint errors or teratogenic interference, and we enter the realm of macroscopic physiological emergencies.
The anatomy itself becomes the primary variable here.
Right. The stakes involve both maternal hemorrhage and fetal viability simultaneously. The physiological volume of blood moving through the pregnant uterus is just staggering. staggering.
It completely alters how we approach an emergency.
So let's apply that to a clinical scenario from the text. For you listening, picture this. A patient at 25 weeks gestation presents to the emergency department with vaginal bleeding. In almost any other medical discipline, if a patient is bleeding, your immediate clinical instinct is to apply pressure or physically examine the source. But the sources establish an absolute do not touch rule here. No digital pelvic exams. Why is blindly checking the cervix so catastrophic?
Because of the risk of placenta previa.
Okay, break that down for us.
So the placenta is this massive, highly vascular organ. It usually implants high in the uterine fundus, but in previa, it implants low, directly over the internal cervical os.
Meaning that huge vascular bed is sitting right at the exit point.
Exactly. So if a clinician performs a digital exam and sweeps a finger across that cervical opening, they could puncture the placental tissue.
Oh, wow. Hemorrhage in that scenario would be immediate and massive.
You could exsanguinate the mother and the fetus in minutes. So the absolute protocol is to perform a transabdominal ultrasound first.
To definitively map the location of the placenta before anything enters the vaginal canal.
Correct. Always ultrasound first.
Okay, so let's say the ultrasound clears the patient of previa. The placenta is safely out of the way, but she is experiencing preterm contractions. The clinical response here is fascinating.
Yeah, it's very counterintuitive.
The first step isn't to immediately administer heavy tocolytics to stop labor.
Yeah.
The textbook says to start with intravenous hydration. I'm trying to connect the dots between fluid volume and uterine muscle activity.
Well, it comes down to the endocrine feedback loop.
Yeah.
Dehydration decreases intravascular blood volume, right?
Right.
So the hypothalamus detects this hypovolemia and signals the posterior pituitary to release antidiuretic hormone, or ADH, to retain water.
And ADH is structurally almost identical to oxytocin,
Exactly.
which is the primary hormone driving uterine contractions.
Right. They were both nonapeptides produced in the exact same region of the brain. When ADH floods the system due to dehydration, it inevitably binds to oxytocin receptors in the myometrium.
Triggering uterine irritability and contractions?
Yes. So by aggressively hydrating the patient, you shut down the ADH release, which then starves those oxytocin receptors of stimulation.
That is a remarkably elegant physiological intervention. You fix a mechanical problem by basically altering the hormonal environment.
It was brilliant.
But what if the issue is purely structural? Like the cervix opening prematurely without any contractions? The text discusses placing a cerclage, which is a literal stitch in the cervix.
Right, but timing and patient history dictate that intervention. A cerclage is indicated for documented cervical incompetence.
Which usually presents as painless dilation resulting in recurrent mid-trimester losses, right?
Exactly. Or if an ultrasound reveals a highly truncated cervix, like maybe 35 millimeters at 18 weeks.
Which perfectly circles back to our earlier point. You wouldn't use a cerclage for a patient with recurrent first trimester losses.
No, because those are genetic errors, not mechanical failures of the cervix. Applying a structural fix to a genetic problem is completely useless.
Right. Now, as the pregnancy advances into the third trimester, the systemic strain on the maternal body peaks, and we face conditions like preeclampsia. The hallmark signs are hypertension and proteinuria.
Very common, yes.
But the diagnostic threshold where it escalates from preeclampsia to eclampsia is incredibly sharp.
It is instantaneous. The diagnosis changes to eclampsia the second the patient experiences a tonic-clonic seizure.
Just one seizure marks the transition. And the standard protocol to stabilize that central nervous system isn't a traditional anti-epileptic drug, is it?
No, we use intravenous magnesium sulfate.
Magnesium.
Yeah, it acts as a membrane stabilizer and a central nervous system depressant. It increases the seizure threshold far more effectively and safely for the fetus than standard anticonvulsants.
Interesting. And the physiological load of pregnancy also complicates baseline medical conditions, of course. For an acute asthma exacerbation, the text notes we still rely on bronchodilators like albuterol.
Because fetal oxygenation is entirely dependent on maternal oxygenation. Reversing maternal hypoxia is always paramount.
Makes sense. And we also have to remain hypervigilant about the hypercoagulable state of pregnancy. The body naturally ramps up clotting factors to prevent fatal hemorrhage during delivery.
It was a great evolutionary defense mechanism, but...
It makes pregnant patients highly susceptible to deep vein thrombosis.
Exactly. And the primary diagnostic tool for severe calf pain isn't a D-dimer blood test, because that would be elevated anyway in pregnancy.
Right. You use compression ultrasonography of the extremity. Visualizing the veins directly allows us to bypass the confusing baseline chemistry of a pregnant body.
Exactly.
And that hypercoagulable state doesn't just vanish the moment the baby is delivered, which brings us to a complex diagnostic challenge in the immediate postpartum period.
Oh, postpartum fevers. These are tricky.
Let's set it up. You have a patient who recently delivered, she develops a high fever, and the initial diagnosis is a standard pelvic infection.
Very common assumption.
You start her on broad-spectrum intravenous antibiotics. But the fever persists, spiking regularly. She might even look relatively stable between the spikes. We are throwing the best antimicrobial drugs at the problem, and they are failing. Why?
You have to look at the anatomy of the infection here. The diagnosis is septic pelvic thrombophlebitis, or SPT.
Okay, what exactly is that?
It occurs when bacteria from the uterine cavity infiltrate the deep pelvic veins, frequently the ovarian vein, and damage the endothelium.
And this damage, combined with that postpartum hypercoagulable state we just talked about, causes a massive blood clot to form.
Right, so the bacteria essentially trap themselves inside the architecture of the clot.
It's like trying to arrest criminals who have locked themselves inside a bank vault. The bacteria are the criminals, the antibiotics are the police, but that solid thrombus is a steel vault door.
That analogy maps perfectly to the pathophysiology. The antibiotics are circulating in the bloodstream, but they simply cannot penetrate the core of the thrombus where the bacteria are proliferating.
So you can't solve this by just increasing the antibiotic dose.
No, you have to blow the vault doors off, so to speak.
So what's the next step?
You order a CT or MRI to visualize the engorged, clotted vein, and then you initiate anticoagulation therapy.
You use blood thinners to dismantle the clot.
Exactly, which finally exposes the bacteria to the immune system and the antimicrobial agents.
This really highlights how similar symptoms demand radically different investigations. SPT is a localized vascular issue. Contrast that with pyelonephritis, which can also cause severe fever postpartum.
Right, but pyelonephritis is an ascending infection. The bacteria travel up the ureters into the renal parenchyma.
The clinical presentation is distinct. Pyelonephritis features severe costovertebral angle tenderness, nausea, and a urinalysis just packed with leukocytes and bacteria.
And those patients require immediate inpatient admission for aggressive IV hydration and antibiotics.
To prevent permanent renal scarring or sepsis.
Yes.
And we see that same threshold for inpatient admission with non-pregnancy infections like pelvic inflammatory disease. Most PID is managed outpatient.
But if the patient has intractable vomiting, severe peritonitis, or a high fever, they are admitted for 5E therapy.
Mostly to prevent a tubo-ovarian abscess, right?
Exactly. A TOA changes the landscape from a medical problem to a potential surgical emergency. If an abscess ruptures into the peritoneal cavity, the resulting peritonitis can be fatal.
Moving beyond the acute environment of pregnancy and infections, we enter the chronic, lifelong timeline of gynecological care. Let's look at abnormal uterine bleeding, or AUB.
Okay.
The clinical approach is entirely dictated by the patient's age. It's essentially the difference between diagnosing a software glitch in a new system versus a critical hardware failure in an aging machine.
That's a great way to put it. Let's examine the adolescent first. Heavy, erratic bleeding in a teenager is almost always anovulatory.
So the hypothalamic pituitary gonadal axis, the hormonal software, is just immature. It hasn't established a reliable cyclical rhythm yet.
Right, so the ovaries are producing estrogen, which proliferates the endometrial lining, but because there is no ovulation, there is no corpus luteum to produce progesterone.
And without progesterone to stabilize that lining, it grows excessively and sheds unpredictably.
Exactly. And this is frequently exacerbated by adiposity, as peripheral fat tissue converts androgens into additional estrogen, worsening the imbalance.
So after ruling out a coagulopathy, like von Willebrand disease, by checking bleeding time, the intervention is basically a hormonal reboot.
Yes. You use a taper of oral contraceptive pills to enforce a synthetic cycle and stabilize the endometrium.
Now contrast that software glitch with postmenopausal bleeding, the hardware failure.
Bleeding after menopause is presumed to be endometrial carcinoma until proven otherwise.
Because the baseline estrogen should be negligible.
Right. If a biopsy reveals complex atypical hyperplasia, the statistical likelihood of concurrent underlying malignancy is severe.
You don't try to regulate that with a pill.
No. The protocol demands direct visualization via hysteroscopy and a D&C to sample the entire cavity.
And if no frank cancer is found but the atypia remains, the definitive treatment is a simple hysterectomy to eliminate the precancerous tissue.
The risk of progression is simply too high to leave the tissue in place.
Speaking of malignancy, the source material presents a truly devastating biological conflict, discovering cervical cancer during an active pregnancy.
That's one of the hardest situations we deal with.
Because the treatments required to save the mother are fundamentally lethal to the fetus?
It requires an agonizing multidisciplinary approach. Deep cone biopsies of the cervix to stage the cancer can induce immediate preterm labor or miscarriage.
So we rely on shallow biopsies.
Yes. And if radiation is required, the localized pelvic dosing almost invariably causes spontaneous abortion. Systemic chemotherapy introduces catastrophic teratogenic effects.
Specifically interfering with fetal cellular division.
Right. The entire management plan hinges on the gestational age at diagnosis and the mother's wishes, balancing maternal survival against fetal viability.
It is a profound clinical tightrope. Shifting gears to a non-malignant but highly disruptive condition, endometriosis. The medical management focuses on manipulating the hormonal environment to starve the ectopic endometrial implants.
We use continuous OCPs, or, more aggressively, GnRH agonists.
And a GnRH agonist provides continuous rather than pulsatile stimulation to the pituitary, right?
Yes. This downregulates the receptors, halting the production of FSH and LH, which effectively induces a profound, though reversible, state of menopause.
The textbook also mentions danazol as an older therapy that is rarely utilized today. Its mechanism is fascinating, but the collateral damage is just too high.
Yeah, danazol is a synthetic androgen. It suppresses the endometriosis, sure, but it carries severe virilizing side effects.
Like hirsutism, deepening of the voice, adverse lipid profiles.
Exactly. The physiological cost is too severe when we have GnRH agonists available.
Let's analyze another endocrine puzzle for our listeners. A patient presents with secondary amenorrhea, and her serum prolactin is elevated. The immediate reflex might be to order a brain MRI to hunt for a pituitary adenoma.
But the text explicitly warns against jumping to advanced imaging.
Why is that?
Because prolactin secretion is highly volatile. A transient spike can be triggered by acute emotional stress, vigorous exercise, breast stimulation, or even just a recent heavy meal.
So if you order an MRI based on a single, slightly elevated lab value, you risk finding an incidental, asymptomatic microadenoma that was never the cause of the amenorrhea in the first place.
Exactly. You end up treating the scan instead of the patient. The logical protocol is to recheck the fasting prolactin and simultaneously draw a TSH to rule out primary hypothyroidism.
And an FSH to rule out premature ovarian failure. You have to map the entire endocrine axis before you go hunting for brain tumors.
That's right.
There is one more diagnostic puzzle in this section that highlights the incredible complexity of sexual differentiation. Androgen insensitivity syndrome, historically referred to as testicular feminization.
This is a fascinating condition.
Yeah.
It typically presents as an adolescent female being evaluated for primary amenorrhea.
Phenotypically, she appears completely female with normal breast development, but her karyotype is 46XY.
Genetically male. The tests are present, usually undescended in the abdomen or inguinal canal, producing normal male levels of testosterone.
But due to a genetic mutation, the peripheral androgen receptors are completely non-functional.
Right, the body literally cannot respond to the testosterone it is producing.
So what happens to all that circulating testosterone?
It undergoes peripheral aromatization. Enzymes in the fat and skin convert that excess testosterone into estrogen.
Ah, and this unopposed estrogen drives the development of female secondary sexual characteristics.
Exactly. However, because the anti-Müllerian hormone produced by the testes function normally in utero, the internal female organs, like the uterus and upper vagina, never formed.
So the phenotype completely diverges from the genotype due to a single receptor failure. Understanding these deep mechanisms is critical because the ultimate goal of gynecological care is preventative maintenance.
Prevention is key.
But prevention is governed by strict statistical and biological logic. Why don't we run a CA-125 tumor marker blood test on every 65-year-old woman to screen for ovarian cancer? It seems like gathering more data would be universally beneficial.
Gathering data is only beneficial if the test has high specificity. CA-125 is an antigen that can be elevated by almost any peritoneal irritation.
Endometriosis, fibroids, PID, even a benign cyst will spike the CA-125.
Right. So if you apply an unspecific test to a broad asymptomatic population, the positive predictive value plummets. You generate a massive wave of false positives.
And those false positives lead to immense psychological trauma and, worse, unnecessary exploratory laparotomies.
We would end up causing surgical complications in thousands of healthy women just to find one early-stage ovarian cancer. the harm drastically outweighs the benefit.
The statistical logic really dictates the age-based screening guidelines. For example, why do we stop performing pap smears on a healthy 71-year-old woman?
Well, cervical cancer, particularly squamous cell carcinoma, is notoriously slow-growing. If a 71-year-old has a documented history of normal pap smears for the last decade, her statistical risk of suddenly developing an aggressive cervical lesion is negligible.
And the risk of a false positive leading to a painful colposcopy and biopsy is much higher. She has essentially outlived the risk timeline.
Exactly. However, she still requires a mammogram, colonoscopy, and bone densitometry for osteoporosis.
But if we look at a 65-year-old with a gap in care, the metabolic screenings take priority. A lipid profile every 5 years, fasting glucose every 3 years, and a TSH every 5 years.
Preventative maintenance.
The textbook also offers a brilliant insight into the prevention of ovarian cancer itself. Taking combination oral contraceptive pills reduces a woman's risk of ovarian cancer by an astonishing 40%.
This is grounded in the incessant ovulation theory. Every single month that a woman ovulates, the epithelial surface of the ovary physically ruptures to release the ovum.
And that microscopic trauma requires immediate cellular repair and proliferation to heal the surface.
Right. And every time a cell divides, there is a minute risk of a genetic copying error, a mutation. Multiply that risk over 400 lifetime ovulations, and the odds of a malignant transformation increase.
Therefore, anything that suppresses ovulation provides a protective effect.
Yes. Oral contraceptives, multi-parity, extended breastfeeding, they all place the ovaries in a state of suspended animation, dramatically reducing the lifetime number of epithelial ruptures.
Conversely, nulliparity, or the use of ovulation induction medications for fertility, increases the total number of ovulatory events, thereby increasing the risk profile.
Exactly.
All of these decisions, from screening to complex diagnostic interventions, operate within a rigid framework of medical ethics. The source material explicitly defines these pillars. Beneficence is the proactive duty to promote the physiological good of the patient.
Non-maleficence is the restrictive duty to prevent harm, like avoiding the unnecessary surgery from a false positive CA-125 we mentioned.
And autonomy dictates that the patient, fully informed of the pathophysiology and the risks, retains the absolute right to self-determination over her own body.
The clinical scenarios in this textbook constantly force you to weigh beneficence against non-maleficence, with the patient's autonomy acting as the final arbiter.
All right, as promised to you, the learner, let's solidify today's deep dive with a rapid clinical review exercise. Put yourself in the triage bay.
Okay, here we go.
A patient at 25 weeks gestation presents with acute vaginal bleeding. Based on the physiological imperatives we discussed, what are your 3 immediate stabilizing actions, and what is the definitive contraindication? Take a moment to lock in your answer.
The 3 immediate steps. Establish FU access for fluid resuscitation, place a continuous fetal monitor, and order a transabdominal ultrasound to map the placenta.
And the absolute contraindication.
Never perform a digital pelvic exam.
Because if it's placenta previa, you will puncture the vascular bed and induce catastrophic hemorrhage.
You secure the data before you touch the patient. Always.
There is a profound disclaimer printed at the very front of this textbook. It states simply, medicine is an ever-changing science. We've spent this session relying on established biological logic, but it leaves you with a provocative thought.
Oh, I like this.
As we map the human genome with greater precision, and as targeted monoclonal antibodies begin to replace broad-spectrum therapies, how many of the absolute gold standard rules we discussed today will be completely obsolete in 10 years?
It's entirely possible.
The pathophysiology remains the same, but our tools for manipulating it are evolving exponentially. Thank you for joining us on this deep dive into the source material. Keep questioning the data, keep studying the mechanisms, and keep applying this knowledge.